Good evening. My name is Daniel Katz. I'm a vascular surgeon at Rush University Medical Center. It's a profound honor for me to welcome Rabbi Dr. Avram Steinberg to Chicago and to introduce this leading world expert on Halawa and Jewish medical ethics to this audience. I want to thank the Chicago Mitzvah Campaign, the CRC, Chai Lifeline, the Agudas, and Refuah 311 for bringing Rabbi Dr. Steinberg to discuss these complex medical issues and religious ethical concerns. Rabbi Dr. Steinberg is the proverbial triple threat. He has it all. He has extensive rabbinic training and can address the issues from a halachic perspective. He's a practicing physician and clearly understands the clinical implications with these clinical and ethical concerns. And he's an academician with robust scholarly activity which he has shared with the world community. Rabbi Steinberg was born in 1947 in a displaced persons camp in Hof, Germany, and came with his family to Israel 2 years later as an infant in 1949. He comes from a long line of prominent Rebbeim. His father was the rabbi at Kiryat Yam, and Rav Steinberg studied at Merkaz Harav in Yerushalayim. He's an advisor to the Knesset. He's an advisor to the Chief Rabbinate of Israel. He's testified thousands of times as an expert witness, both as a rabbi and as a physician, advocating for the patient and the family. His medical education began in Hebrew University Hadassah, where he graduated in 1972. He then undertook a pediatric residency at Shaare Zedek, and then specialized as a pediatric neurologist with a fellowship at Albert Einstein and Montefiore Hospital in New York. He's a senior pediatric neurologist at Shaare Zedek and Bikur Cholim hospitals in Jerusalem. Amongst many, many, many titles, he's the Director of Medical Ethics at Shaare Zedek, Director of Yad Harav Herzog Institute. He's also the co-chair of the Israeli National Council on Bioethics. His scholarly activity is robust. He has written the penultimate multi-volume treatises on halacha and Jewish medical ethics, which are exceedingly well referenced. They're readable. They address common clinical scenarios in almost every discipline. These are issues that we face daily as clinicians. He's also the head of the editorial board of the Talmudic Micropedia, which now addresses new ongoing issues in medical ethics. He has a multitude of books, chapters, named lectures. His CV is very, very extensive. We are truly fortunate to have the opportunity to hear from such a giant in the field. Rabbi Steinberg will present a short lecture, and then we'll open the forum up to questions. There are going to be opportunities for you, note cards for you to pass questions up to the front, and we'll try to address those questions. Ladies and gentlemen, please join me in welcoming Rabbi Dr. Avram Steinberg.
Thank you very much for this eulogy. I'm really very pleased and honored to be here in Chicago and to address you on end-of-life decision-making, which is really a very, very difficult topic, a topic that is not theoretical. We face it daily, those of us who practice medicine. And actually, everyone, even if he's not in the medical field, either his parents or other relatives, and eventually we ourselves will face these issues. And the more complex the treatment available is, the more difficult the dilemmas are what to do in these situations. What do you do? How do you move it? There's no presentation? Okay, I thought it would be more convenient to follow me looking at the slides. Okay, so without. The issues that we deal with are related to the options that we have in treating end-of-life situations. Up to quite recently, let's say 50, 60 years ago, when there was a debate how much to intervene and what to do for a patient to either live longer or live shorter, the difference between intervening and not intervening was almost the same. There was very little that we could do in order to prolong the life of dying patients. Today, we have many, many tools that are effective in prolonging life, and the question that faces us in reality is, how much should we invest in intervening to prolong life? Is it every life? Is it for everyone? Can we withhold certain treatments? Can we withdraw certain treatments? Can we even shorten the life actively, causing euthanasia or physician-assisted suicide? There are many options to treat end-of-life situations. So let me start from the principles behind the questions on how much to intervene when we have a patient who is very sick. The first question is, how do we define a dying patient? The term used in the English language is a terminal patient, which I think is almost a nonsense term. Because if he is terminal, it means that I am immortal, right? Actually, we all are terminal. What's the difference between the person who will die in a week or a person who will die in 70 years? Both patients are terminal. At some point, they'll die. So the term terminal doesn't really add anything to understanding the situation that we are facing. We prefer to use the term a dying patient who has a terminal illness. The illness might be terminal in a sense, or should be terminal in a sense, that there is no cure to the basic disease that will cause, at the end, for the patient to die. So he has a terminal, fatal illness, but he is a dying patient. Now, when does he start to be a dying patient? If he is now sick with a cardiac disease, or with a renal disease, or with a cancer, he may still live another 20 years with this situation. It will be at the end terminal, it will kill him at the end, but at what point are we changing the terminology and our attitude to the patient because he is now dying? So to add to the definition that he has a fatal, incurable illness that will lead to his death, we need to attach a time frame. And this time frame will be the time where he will start to be called a dying patient, and then we can use different approach to the treatment of this patient. So conveniently, most legal legislations all over the world accepted 6 months as being the point between someone who is still not a dying patient and someone who starts to be a dying patient. The reason for it is that in many illnesses, we can prognosticate approximately 6 months. We can't prognosticate longer time. If we would define that a dying patient is someone who will die within a year, then it will be just guessing if he is dying in a year or not, because we don't have really statistics almost on any disease for such a long period of time. But half a year, in many diseases, there are enough statistical data to tell that if the APC happens, then the time span is another 6 months. So that is a definition of a dying patient. A dying patient has a different category as far as treatment is concerned, because he is dying and because the disease is incurable. Now, there are various approaches, as I mentioned earlier, to a dying patient. The major ethical issues involved in decision-making in a dying patient are the value of life and the principle of autonomy. On the side of the value of life, if we accept life per se as a value, no matter what type of a life, it can be a life that does not allow someone to sit here and listen to this boring lecture. That would be a quality of life that is maybe less than what we have, but it's still a life. The person is alive, and he has a value as a live person. Life per se has a value. On the other hand, is the principle of autonomy, which means that we ought to respect the wishes of the patient. We are not deciding for him, he is deciding for himself, provided we gave him all the information, we made it in a way that he can understand it, and once he understood it, he can give an informed consent that he wishes that this and this should be done for him, or this and this should not be done for him. Now, if either of these two values would have been absolute values, and in philosophy, absolute value is a value that there are no exceptions to it ever, then our task as physicians would have been very easy. For instance, if we would say that the value of life is an absolute value, an infinite value, that would lead to the conclusion that no matter what the situation of this patient is, we ought to do everything possible to prolong every minute of his life. Because 1 minute, if you will say, is not important, then the next question will be, how about an hour? And if an hour is not important, what about a week? And if the week is not important, what about a month? So if the value is absolute, so 1 minute and 70 years have the same parameters, and therefore we should extend every life by all available means, no matter what the situation of the patient is, in order to fulfill the value of life, if we take it as an absolute value. The same can be on the other side of the equation. If autonomy, if the principle of autonomy is an absolute value, then whatever the patient wants me to do, I have to do. So if he walks in to the hospital and he says, I have a disease that will kill me in 6 months, I don't want to live the 6 months. I want to die now. I want you to do something that I will die now. So what would be the option? Take out a pistol and shoot him. So in hospitals we don't walk around with pistols, but we have means to kill him right away, because this is what he wants. If we respect autonomy as an absolute value, then whatever he wants, we should do for him. Most countries, most ethicists, most physicians, most rabbis do not accept either side of the equation, nor the value of life as an absolute value, and nor the value of autonomy as an absolute value. So we have now two values that are very important, and sometimes they contradict each other. Because sometimes the patient autonomously doesn't want to get certain treatments or wants to stop certain treatments in order for him to die, But that would violate the value of life, because in doing so, we are taking away his life. We are shortening his life. Or on the other hand, a patient may want to have everything done to him no matter what, and we can't supply him everything to do to prolong whatever time he wants. So what do we do when we have this type of contradiction? So here there are different philosophies, and I think it is important to realize that patients come from different cultural, religious backgrounds, and they are entitled to have their way as long as it is within the parameters of what society is accepting. So it is not me as a physician to dictate to the patient what I think would be best for him, because then I'm violating autonomy. Autonomy is all about respecting what the patient wants despite the fact that I disagree with him. Because if I agree with him, then I'm not respecting autonomy, I'm respecting myself, right? So you need to realize that patient A doesn't want a certain treatment, and patient B wants this treatment because of his value system as opposed to the value system of someone else. And that, in a pluralistic society, has to be accepted and understood. So from a secular point of view, in most countries, including the United States, there is no distinction between withdrawing and withholding treatments. So that if a patient says, I don't want to live longer, and we do not accept his wish to kill him, where certain countries do accept it, and if time permits, we'll discuss it, we are limiting his autonomy to the degree that he can't ask us to kill him or to assist him in suicide, except for Oregon and 4 or 5 other states here in the United States. I think in Illinois, physician-assisted suicide is still illegal. I'm saying still because it may change, and maybe next year when I'll be here, you'll tell me differently. But at the moment, this is the state of the art in this country, in this state. So we are limiting the autonomy of the patient. He says, I want you to do something that I should die now, and we don't listen to him. On the other hand, if he says, okay, I understand you can't kill me, I understand you can't assist me to commit suicide, but I want you to stop every treatment so that I'll die as soon as possible for my illness. So the concept of secular ethics is that there is no distinction between withholding treatment and withdrawing treatment. And hence, if the patient says, if I'll need to be intubated, I don't want you to intubate me, that will be equivalent to a situation where he is already intubated and I am pulling the plug and withdrawing this treatment that is still keeping him alive. That, from a secular point of view, is the same. From a Jewish point of view, and there are many other places in the world that have the same idea, not from a religious point of view, there is a distinction between omitting and committing. There is a distinction between not putting someone on a respirator versus taking him off the respirator, which is an act that will cause him to die. So even if he asks to be disconnected from the respirator, this autonomy is limited because of the value of life. The same way as his autonomy is limited if he wants me to kill him. In a way, the act of removing a respirator with the intention to lead him to die, not as a weaning process, which is a medical procedure which everyone agrees is okay, but with the intention for him to die, is an act which is similar to an act of killing him. Because we do something that causes him to die by our act, not by our omission. So these are philosophical differences in describing what is permissible and what is not. In other words, everyone agrees that autonomy is limited. It can be limited at the edge of killing someone. It can be limited at the edge of assisting him to commit suicide. And it can be limited in an act that will lead to his death by removing a certain treatment. That is one side of the coin. The other side of the coin says, yes, we are limiting his autonomy. We are not killing him even if he wants. We are not assisting him to commit suicide even if he wants. But if he wants me to act on a treatment modality, I can do it and that would be okay. So these are two different approaches. And again, the patient has to lead us what value system he lives by in order for us to decide which act would be permissible and which act would not be permissible. So that is one major difference between secular and Jewish law. Another important distinction is the type of treatment. Providing sustenance, providing food and fluid is not a medical intervention. We all here are eating and drinking in order for us to survive. That is not a medical procedure. We're not eating and drinking as a medical procedure. We are eating and drinking as a sustenance to keep us alive. The same holds true for a patient who is dying from an illness that is unrelated to food and fluid. So he will die of his cancer, he will die of his heart failure, but if we'll starve him to death or if we'll dehydrate him, he will die sooner from starvation and dehydration than he would have died from the disease that made him a dying patient. So again, in a secular world, because I think that is the major argument, because providing sustenance in certain dying situations has to be done by a vehicle that is not natural, by an NG tube or by a pad or by an IV. These are unnatural vehicles to provide sustenance. Therefore, we call the whole system a treatment, and if the patient chooses or if we decide for the patient not to treat him, there is another form not to treat him, which leads to not providing him sustenance. But if we look at sustenance not as a form of treatment, but as a natural support for physiological existence, it doesn't matter by which vehicle we provide it. We can provide it by mouth, we can provide it by an NG tube, we can provide it by a pad, by an IV. The food and fluid is the same whether it comes through the mouth or whether it comes through the pad. So therefore, by Jewish law, providing food and fluid is required as a sustenance rather than as a treatment, except for one condition. If this provision of sustenance has a medical contraindication. So for instance, if someone is in renal failure and we'll give him a lot of fluid, that will be medically contraindicated. But to avoid giving sustenance from a philosophical point of view, because we want the patient to die, that by Jewish law is not acceptable. And that is another difference between secular and Jewish law treating end-of-life situations. And a third important distinction is the quality of life of the patient that we are treating. Quality of life, in many definitions, has become something that overrides the value of life itself. So life is dependent on its quality. So if we relate to a patient that has a low quality of life, then we take away the value of life, and therefore we let him die. That can be true for a persistent vegetative state, for a demented patient, for a very old and frail patient. All these patients have a different quality of life than we would like, and perhaps that he himself would have liked when he had a better quality of life, and therefore we relate to him differently than we relate to a person who is competent and alert and awake and is doing other things. That, from a Jewish point of view, is wrong. Who are we to decide what quality of life is worth living? And how do you define such a quality of life? Is an IQ of 20 a quality of life not worth living? Is an IQ of 30 a quality of life not worth living? Is it dementia that he forgets a few names, he forgets his wife from time to time, and he recalls it the next day? Is this a situation not worth living? That is a very difficult concept to define in any circumstance. Certainly, from a Jewish point of view, it is unacceptable per se. Now, if the quality of life is combined with survival, if the dementia reaches such a stage that he is going to die, demented people at some stage die from this disease, then he is becoming a dying patient, and all that we discussed, what is allowed and what is not allowed, can be applied. But before then, the fact that he is not communicative doesn't mean that he doesn't have a right to live, and doesn't mean that the value of life has been taken away from him. Even if he's at a stage that he can't take food by mouth because of his demented situation, we are still obligated to sustain him in different ways, like any other person who needs sustenance in a way that will keep him alive. So these are some of the issues that I think we should discuss when we'll open the floor to questions. But I think what is important to realize is that there are different sets of values. It is not that one value is better or worse than another one. There are different sets of values, and if we go by the principle of autonomy, we ought to respect the system and the value of patients according to their beliefs. It is also important to realize that at least in observant Jews, the questions are not purely medical questions. There obviously are medical questions, but the question whether or not to give a certain treatment, which medically we can explain either the good side of it or the side effects of it, and why is it better or worse from a medical point of view, there is still the value system applied to it. And therefore, in many instances, it is not only the physician that can make such decisions, but it has to be done in combination with the spiritual leader who is versed in the ideas of what is right and wrong to do in these certain situations, and therefore a combination of, if we talk about Jews, observant Jews, a combination of a competent rabbi who knows all the facts and understands the realities of dying patients, together with a treating team to make the most appropriate decisions for this particular patient. So this combination is very useful, and I think is almost a must if you want to respect the autonomy of this particular patient with his particular value systems. And finally, there is one distinction that I think is important to realize from a Jewish point of view, and that is, how do we define withdrawing and withholding treatments? And the interesting point is that from a Jewish point of view, the fact that we as physicians say we need to intubate him and we put him on a respirator, or we need to dialyze him and we put him on a dialysis machine, or we need to give him chemotherapy or radiotherapy, the fact that we gave this order now doesn't mean that it goes forever until the patient dies. There are ways to get out of it in certain instances. And what are they? So we distinguish between a continuous form of treatment and a cyclic or intermittent form of treatment. So that, for instance, how do we treat a patient who needs dialysis? We bring him in Sunday morning, we hook him up to the machine for 4 hours, we take him off the machine after 4 hours, and he comes back on Tuesday, and again we hook him up for another 4 hours, and so on. So from a medical point of view, he is getting dialysis. From a Jewish point of view, each unit is a new decision. We gave him the treatment on Sunday, the treatment finished. If we see it's beneficial, or if the patient wants to continue, or if the team thinks that there's still chance to help the patient, so we'll give him the next unit. If he's dying, and there's no point in continuing the dialysis, so we are withholding the further unit. So that is a form of withholding despite the fact that we started the treatment. Whereas a respirator, for instance, you can't do it. You can't take a patient who is a respirator dependent, invite him on Sunday for 4 hours to put him on a respirator, send him home, and ask him to come on Tuesday. He will never come back, right? So that is a continuous form of treatment, and therefore this is an example of withdrawing the treatment, which causes the patient to die. And if you come to think about it, there are actually only 2 treatments that are of this type. All the rest are intermittent treatments. It is a respirator and a pacemaker, or a pacemaker which is a continuous pacemaker, not on demand. In these 2 situations, the treatment has to go on all the time, and if you stop it, you do an act of withdrawal, you did an act from a Jewish point of view of hastening death. Whereas if you stop an intermittent treatment, you stop it as a withholding way of the next session because it's not a continuous treatment. So these are some practical issues that can be helpful in situations where the patient is dying. And finally, one word about palliative care. A dying patient, by definition, is a patient that has a fatal and incurable illness. So we can't cure him. We can't save his life. We can prolong it a little bit, or we can choose not to prolong it. But we can't cure it. Many times, a dying patient is suffering from terrible pain. That becomes, from a Jewish point of view, the new illness of this patient. And this illness is a treatable illness. And you have to treat it. Despite the fact that occasionally the treatment to alleviate pain may hasten death. If you give morphine in order to stop the pain, occasionally it can cause respiratory depression. That is not different than treating a patient with a brain tumor that you take him to the OR and 5% die on the table. It doesn't mean that because there is a certain amount of mortality that we are not going to treat all patients. 95% will die of the brain tumor because 5% are dying on the table. So the same is here. If we view the pain of end-of-life situations as the disease of this patient that can be treated, we ought to treat it. Now, palliative care today has really advanced tremendously, and the tools to alleviate pain are very, very effective, and in fact, not hastening death. It is rare that the patient is dying because of the palliative care, and if you do it correctly, not only doesn't it kill him sooner, but some patients, it is even a measure to prolong life, because pain produces all kinds of chemicals that by themselves shorten life. And if you control the pain, some patients live even longer, not only better, but longer, due to the palliative care. So palliative care is a must, and we have to do it correctly, not with an intention to kill him and cover it by saying we're just giving you palliative care. Obviously, you can give 50 milligram morphine and kill the patient and say, I just wanted to alleviate his pain. That obviously will be wrong ethically and medically. But if you know how to treat the patient and you know how to titrate the medication, there's no reason for him to die of it, and if here and there a patient really died of it, it's not different than any other intervention that has side effects, including mortalities. So this is some of the major issues that I think are relevant to treating the dying patient, and some of the differences between the current secular approach and the Jewish approach. And by the way, until the story of Karen Quinlan in the 60s, secular medical ethics was very similar to Jewish medical ethics. The value of life was very respected, and nothing was allowed to be done to shorten life. Since then, a gradual change has occurred. From a secular point of view, it can be regarded as an advancement. From a Jewish point of view, it can be regarded as a slippery slope, and it depends on how you look at the end results. And today, secular ethics has changed dramatically from what was only less than a few decades ago, for reasons that ethicists have their explanations, and we respect them, but they are different than the way Jewish law and Jewish ethics view certain treatments of dying patients. Thank you.
So if there are any questions, if you want to pass it toward the center, we'd be happy to field with Rabbi Steinberg. So one question from the floor is, what is the halachic current view on brain death?
Well, I guess you don't want to stay until tomorrow morning. That is a different topic. I will say a few words about it, but it will do some disservice to the issue. It has nothing to do with a dying patient. It has to do with the definition of death. So we are one step further from our discussion. Now, it is disputable between the rabbis, current rabbis, how do you define the moment of death? It is clear that the moment of death, no matter what definition we take, except for one which I'll mention, is an artificial definition from a medical point of view. It is artificial because we are talking about a process of dying. There's no moment of death, there is a process of dying. And in this process, certain organs and certain tissues die earlier, and others die later, depending on their affinity to oxygen, to glucose, and so on. So, for a legal purpose, or from a halachic purpose, or from an ethical purpose, you take a point in the process of dying and you say, if this point happened, we regard this patient as a dead person, although parts of his body are still alive. And as you may very well know, even after we bury a person, there are still live parts in his body that continue to be alive for days in the grave. So medically speaking, there's only one moment of death, and that is when all tissues, organs are dead. And that, on the average, happens around 3 days after the heart stops, after cardiac death, which is acceptable by everyone. So medicine can't help us in deciding what is the moment of death. It is a social, philosophical, religious, legal decision in the process. Now, in this process nowadays with the respirator, let's start before the respirator. Before 50, 60 years ago, the moment of death was defined when both respiration and cardiac function ceased, irreversibly. The issue was that both these signs occurred within minutes from each other. If the heart stopped, then breathing stopped within minutes, and if breathing stopped, because of brain damage, the heart stopped within minutes. Once the respirator was invented, we can now separate in time between the two signs. Respiration ceased, but we give him a respirator. So the heart continues to function because he gets what he needs via the respirator. So the question is, which of the two signs are the signs that are acceptable as the moment of death? Is it the respiration, and then brain death is acceptable as the moment of death? Or is it the cardiac function, and then the fact that he can't breathe on his own and the brain is destroyed doesn't matter, because the heart is still functioning normally, and therefore he is still alive. That is the dispute. And by the way, from a halachic point of view, brain death is not the right definition of what we agree if we agree to this definition. Because the brain per se is not the organ that decides whether the person is alive or dead. What decides whether the person is alive or dead is if he is breathing on his own or not. Now, if I'll do the following. I wasn't breathing now, right? Am I dead? If respiration is the sign of death, and I didn't have the action of respiration, am I dead? I assume you'll say I'm not dead, right? Hopefully. So why am I not dead? I didn't breathe. The reason is that it's reversible, that after a minute I'm starting to breathe again. So if you define a person as a dead person when respiration stopped, you have to prove that it stopped irreversibly. And the way to prove it is by brainstem destruction, because respiration is totally dependent on the brainstem respiratory center. So if he is brain dead, from a halachic point of view, it means that he is dead because he is not breathing and it's an irreversible situation. That is the halachic definition for those rabbis who accept this definition. Those rabbis who still claim that the heart is part of the definition whether the person is alive or dead, as long as the heart is functioning, he is still alive, despite the fact that his brain died and he can't breathe anymore. It's a philosophical question, and we as scientists can't help to resolve this situation.
A basic primary question is, what is the source for autonomy in Jewish law? And follow-up question is, what is the obligation of a Jewish doctor who respects the autonomy of the patient and is asked to do an act which violates their halachic principles?
Okay, so as opposed to the current secular approach, as you know, for many, many generations, a patient-physician relationship was a paternalistic relationship, which means that autonomy wasn't respected at all. A physician treated the patient as he found best for the patient, without talking to him, without asking him, without disclosing to him anything. That, in my lifetime, and I'm not an ancient person, in my lifetime, I practiced medicine that way when I was a resident. There was no notion of autonomy. I did what I thought is best for the patient. That was how medicine was practiced since Hippocrates. If you read the Hippocratic notes, you'll see that he teaches his students, don't relate at all to the patient because he knows nothing. Why do you ask him? What's the reason to ask him? He knows nothing. You do what you think is best for him. By the way, what he knew was as much as the patient knew. He didn't know much more. But the idea was that I am the expert and I know what is best for the patient. That has changed dramatically to an autonomous approach in a patient-physician relationship, which means that I'm just a technician. You bring a car to the garage, and he tells you the brakes aren't good, the wheels aren't good, the tires aren't good. Tell me what do you want me to correct, and you'll pay for what you want me to do. I don't impose on you anything. That is how full autonomy is viewed in the patient-physician relationship. I am telling the patient everything I know about his situation, and he is telling me what he wants. He wants the treatment, he doesn't want the treatment, he wants parts of the treatment, and I have to follow what he says. That is the extreme autonomy. In Judaism, there is a middle way. It is not entirely paternalistic, but it is not entirely autonomous. Because if the patient requests autonomously, after having told what exactly the situation is, if he chooses a direction which is harmful to him, I am not allowed to respect his autonomy. If I have a patient with a gangrenous leg, a diabetic patient with a gangrenous leg, and in order to save his life, I have to amputate a few fingers, otherwise the necrosis will go up and septic and he'll die, and he says, leave me alone. By Jewish law, it can't be done because by the law of the land, you can't do it. But by Jewish law, I shouldn't force him to amputate the fingers in order to save his life, because life is more important than autonomy in this instance. But by common acknowledgement of the importance of autonomy, if I don't get an informed consent from the patient, even if I know that his decision is very harmful to him, I have no choice. I have to respect his autonomous wish. Now, if the patient wants me as a physician to do something that I as a physician cannot do because of my conscience or because of my religious understanding, it is in many countries, I don't know here, but certainly in many European countries in Israel, it is my right to abstain from treating the patient. The same way as the patient has an autonomy to get what he wants, I have an autonomy not to be forced to do something which I think is absolutely wrong. So the patient may at the end get what he wants by maybe another physician who agrees to do it. But why force me to do it when I think that this is something that I am not allowed to do it for whatever reason? It can be professionally, it can be religiously, it can be ethically, whatever reason. If I am in a position that I am not comfortable to do it, I should have the right not to do it. Many laws in many countries apply, for instance, to abortion. By law, women may have abortion almost at will. By some standards, Catholic and Jewish and others, abortion in such circumstances is not permissible. So if I am the gynecologist who has to perform the abortion, I should have, and I do have in many countries, the right to say, I won't do it. You have your autonomy. At the end, you'll find someone to do it and it's fine, but you can't impose it on me that I should do something that conscientiously I think it's a wrong act.
There have been a couple questions regarding intermittent ventilation, for example, in a patient with muscular dystrophy who has nighttime ventilatory needs. Can that be withheld as the condition progresses? Is there a specific time frame for intermittent ventilation?
Yes. The answer is yes. And in fact, in the old days, when oxygen didn't come from the wall constantly, but there were balloons of oxygen attached to the respirator, if the balloon ran out, it's the same way as a dialysis. Once the unit finished, and I have to re-imply the new unit, I don't have the obligation to do it if circumstances are such that I wouldn't start the respirator to begin with, I would withhold it. Now that it's intermittent, I am allowed not to do the next one. That can be true for ALS and for other degenerative diseases where at a certain stage a respirator is required intermittently, so that if the patient wants to try it and he tried it for a while and he can't take it anymore, and anyway he is disconnected from the respirator periodically, it is not different than any other intermittent treatment.
Are there any circumstances when sustenance, fluid fluids or nutrition can be withheld besides a medical contraindication as a dying patient refusing all food and fluids? And similarly, must a PEG be placed to deliver these?
So, the real exception to provide sustenance is a medical contraindication. Sometimes, technically, it is impossible to provide the vehicle to give the sustenance. Let's say the patient is very ill, and the procedure to put a PEG in is by itself dangerous. It's not that the food will cause him trouble or the fluid will cause him trouble, but the procedure will cause him trouble. That is a medical contraindication, and that we have no choice but to accept. In fact, I advise my patients, I'm a pediatric neurologist, I have dying patients who are not adults, who are children, who have neurodegenerative diseases, and at some point they stop eating. So I advise them to place a PEG at an early stage when they still can eat by mouth, and they should continue to eat by mouth. But now they are healthy enough to undergo this procedure. They have the PEG, they close up the part that goes out of the PEG, they don't use it for the time being, and when they get sick or they deteriorate, then you have an open line already, and you can continue to supply sustenance without the fear that now to do the procedure will cause a medical problem. And many of my patients are very happy with this idea that they know that if time comes, they have already a PEG in place, and they could do it the way that they think is the right way. Obviously, those who hold that it's a form of treatment and you're allowed to stop it, they wouldn't prepare it, but they will wait for the thing to happen and then say we can't put a PEG in. And many of the studies that show that putting a PEG is not making any change are studies where the decision to put the PEG is in a very advanced situation. Then it's true. At this stage, it really is not helpful. Sometimes it's even dangerous. But if you do it ahead of time, when everything works well, even though you don't use it, you have an open line for the time that you might need it.
There's a question regarding cost and rationing as it relates to end-of-life decisions from both an individual and a policy perspective.
Right. So that is really one of the major issues that public policy is disturbed with treating end-of-life situations. There are studies that show that the last year of life costs more than the entire life up to this last year. So it's a costly situation. I have doubts whether the statistics are correct, because the way it's done, it takes into account every procedure that is needed to do, including an MRI or a CT scan, and that costs money to do it, but it really doesn't cost money, because you already bought the machine. You can't include the cost of the machine when you do an MRI to a patient. That is for economy reasons the right way to do it. But for real, this is not more expensive if you do another X-ray. That is really not a real expense. But there are expenses. Now, the issue is, what happens if due to money you let people die? First of all, from a philosophical point of view, it is problematic to say that because I want to save money, I'm letting this person die. But even if you argue, and maybe correctly, that I'm not just saving the money for no good reason, I'm saving it to do something else which is better than keeping this patient still alive. The real problem in my view is that it is not a closed circle. If the budget would have been a closed budget, and you save money here, and it right away goes to something that is directly better than what you did up to now, that would really cause a dilemma that should be taken into account. But the budget is an open budget. So if you let this patient die because of money, he died, that's a fact. Now, the money that you saved, where does it go? For instance, it goes to pay me to come to you to talk to you. Is this worthwhile trade-off? You never know where this money goes to. And it may go to things which might be important, but not as important as keeping the person alive. So because there is no way to know if you save the money that you really do with this particular money something better than keeping the patient alive, I think that this argument is problematic from an ethical point of view. From a halachic point of view, there is a permission to the policymakers to make decisions that at the end will cost the life of people. For instance, a head of a hospital, director of the hospital, is allowed to assign 6 ICU beds and no more, and with the rest of the money, build a good garden around the hospital. It should look nicer and people should have a better quality of life when they are in the hospital. Does a garden compare to another life? Why not put the money for another bed in ICU and save someone else? We are allowed to take such decisions. We are doing it all the time. So that is an a priori decision. If I decided that there will be only 6 beds, and I have my calculations that from the rest of the money I'll do a department of dermatology, although in most instances no one will die if he won't go to the department of dermatology, yet it is a quality of life matter, and it's important to treat people who have skin diseases. It is not life-saving in most instances. Another ICU bed may save life, but I'm allowed to distribute the money what the public is in need of, not necessarily to save life. But that is an a priori decision. If you do this decision at hand, when you have a patient and you are causing him to die because of rationing, that to me is a major ethical concern, because the money not necessarily goes to better expenses, whereas for sure this patient is dying.
Next question is, what is the halacha regarding the decision to do not resuscitate a DNR order?
So I said, if we are dealing with withholding treatment, that, if the circumstances allow, is a legitimate decision. So for instance, if the patient is a dying patient, he has less than 6 months to live, and no matter what we'll do, he will die within this period of time, and he chooses not to be intubated, then the order of DNR is a legitimate order halachically, provided the patient is suffering, not only has a short period of time to live, but suffering at that time. The problem is, how do you define suffering? What is suffering in order to allow a DNR order? So there are some rabbis who say that suffering has to be real suffering. You see that the patient is in agony, is in pain, or even a psychological pain. He can't withhold. So what about a comatose patient that supposedly doesn't feel anything, he's not suffering, but he wrote an advance directive that if he will be a dying patient, not only comatose, but a dying patient and comatose, he doesn't want to be intubated. Are we allowed to fulfill his wish and not intubate him? So here there are 2 schools of thoughts. Some of the rabbis say, in this case, we won't allow it because he's not suffering, he's comatose. Another school of thought says, how do you know that he's not suffering? Whoever was in a comatose situation and came out and remembered whether he suffered or not. We don't know it. And in fact, functional MRI shows that people who look like in a total vegetative state have understanding. When you do studies on some of the PVS, of the persistent vegetative state patients with a functional MRI, and you say all kinds of sentences that are meaningful to the patient, or you give him certain orders, he obviously doesn't show that he understood anything and he's not fulfilling the orders, but the areas in the brain that were supposed to do what we expect to do light up, which means that he has an awareness. We don't see the awareness. We don't know that he has awareness, but apparently he has. So it's not to say that every comatose or vegetative state has this awareness, but certainly a good number of people still have it. And by the way, it's an important lesson for us clinicians when we come to the bedside of a comatose patient, not to talk nonsense or to talk about him or to say all kinds of things, because he might understand what we are saying, and that might be very detrimental to him. So some rabbis say that any dying situation, by definition, is a suffering situation. And therefore, if he fulfills the condition that he is a dying patient and he doesn't want to be intubated, he does not have to be intubated as a withholding procedure. Now, if we don't know what he wants, so the default is to save his life. That is always the case, even from a medical point of view. Any patient that comes into the ER and we don't know anything about him, if he needs treatment, we treat him. And later, we think whether we should continue the treatment or not continue, but first we treat. So if we know what the patient wants, either because he's now competent and tells us, or because he wrote an advance directive or appointed a surrogate and he told him what exactly he wants or doesn't want, withholding treatment is respected.
In a similar vein, is there a minimum percent efficacy before proceeding with a particular treatment?
Again?
Is there a particular percent efficacy before we can proceed with the treatment? Is there something that we say this has a 30% efficacy, therefore we should proceed, and below that we shouldn't recommend?
Well, first of all, I think that all the numbers that rabbis ask us and we give them are usually fictitious numbers. They are maybe good for large statistics of hundreds of people, but individually, we as physicians don't know how to really assess it. So I personally don't give numbers to rabbis if they ask me, unless it's really something very clear. But then they don't need me, they see themselves. But if it's something that my knowledge statistically has to affect the decision, I don't think the numbers mean anything. And I think the professionals here can agree with it. So it has to be reasonable. Now, if someone has metastatic cancer all over and he has a heart failure, to say that if he'll get a heart transplant, he will survive longer, that would make no sense. You don't need my statistics to say that that is not something that we would recommend to do in this situation. So I think it's more what you assess reasonably rather than giving numbers. There is an opposite situation where the intervention causes a risk. In other words, if I'll operate on him, he has a risk of 30% mortality, 50% mortality, 90% mortality. Is there a number here that I should avoid the treatment because of the risk of mortality due to my treatment? So here, most of the rabbis either give a 50% limit or even no limit, as long as there's 100% mortality on the one hand, and there's 10% chance that the operation will succeed, even though by operating, I'm hastening death, he's dying on the table, still he has 10% more than if I won't intervene. And some say that it has to be 50-50 at least. There's one opinion that says that no more than 30% risk is allowed, even if not treating is 100% mortality. And I don't know if we are finishing, there are more questions. If we are finishing, I'll tell you a story. One of the really leading rabbis of our generation, he was 90 years old, and he had a dissecting aneurysm of his aorta. And he obviously fainted and was taken to the hospital. It was a small leak, and it stopped, and he was still alive. But it was clear that the next day or two, it will rupture and he'll die. So he needed an operation in order to strengthen this part of the aorta, to graft this place. So he asked, what are the risks involved? And in the hospital that he was admitted to, they said if we do it, it's a 50% mortality. In your age, in your anesthesiology, in your background medical situation, it's a 50% mortality. He said, you can't do it to me. I allow up to 30%, and I say it for others, I certainly will say it for myself, knowing very well that he will die. But he said, I can't take a 50% mortality, that you'll kill me 50% by doing this procedure. So, because he was a very famous rabbi, they went and looked all over the world for a solution, and they found one surgeon in Columbia, in New York. They didn't give him the background, the numbers and nothing, just this is the condition of this particular patient, what are the chances? And he said, if I do it myself, with my team, with my anesthesiologist, 30%. So they flew in the whole team, and he was operated, he agreed to be operated, and he was successful, and he lived another 12 years. He was 90, and he died at the age of 102. So he was successful because he said that in his hand, it's a 30% mortality, and according to his position, that's the maximum that you're allowed to take. But if he would have asked other rabbis, not himself, they would allow him even 50%. And there was no need to bring a whole team from the United States. But that was his position, and that is how it happened.
So I think the take-home message for me as a surgeon is never more than 30% mortality. This has been incredibly informative. Thank you so much for coming and sharing your knowledge, and I encourage you to look at his textbooks. They're very, very informative. Thank you very much.